It is an honor and a pleasure to introduce today's speaker, Dr. Carlos Cordon-Cordo, MD, PhD, who is the Irene Hines Given and John Laporte Given Professor and Chairman for the Mount Sinai Health System Department of Pathology. Dr. Cordon-Cordo obtained his MD from the Autonomous University of Barcelona in Spain and his PhD in cell biology and genetics from Cornell University Medical College. He created the Division of Molecular Pathology at Memorial Sloan Kettering Cancer Center and served as its first director. Prior to joining Mount Sinai, he served as Vice Chair of Pathology, Professor of Pathology and Urology, also in the Comprehensive Cancer Center at Columbia University College of Physicians and Surgeons. Dr. Cordon-Cordo has outlined a broad vision that redefines the discipline of pathology and places it at the core of patient management and individualized medicine. He was born in Calella. I'm not sure if I'm saying that correctly, Carlos.
Yes.
Okay, a seaside town in the province of Barcelona, and was determined to study medicine and pathology from his childhood days when he asked for a microscope for his 10th birthday. This passion never left him, and his career has been groundbreaking on many levels. Considered one of the pioneers in oncologic molecular pathology and the mechanisms of tumor suppression, he has authored over 500 academic papers and numerous book chapters. He's on the Thomson ISI list of the top 250 researchers in clinical medicine, and in 2013 was named to the list compiled by Stanford University and SciTech Strategies of the world's 400 most influential biomedical scientists. He is particularly renowned for his research in the molecular pathophysiology of prostate cancer, an interest of mine. So imagine my delight when I heard that he was relocating from Columbia to Mount Sinai in 2011. Shortly after arriving here, I had the opportunity to interact with him as part of a PhD doctoral thesis committee for a gifted young scientist. I was truly awestruck at the time, the attention, and the courtesy that he extended to the student and to the task. Indeed, he has served as a beloved mentor and advocate for over 70 investigators throughout his career, a true mensch, as we say at Sinai, a human being. This past fall, when my spirits were at an all-time low due to the pressures of life and COVID, I heard him speak on Zoom about his Herculean efforts here at Sinai regarding the pandemic, the subject of today's talk. As he spoke, the fog lifted, and for the first time in many months, I felt the thrill of scientific discovery and possibility. Indeed, I could feel that enthusiasm of the 10-year-old boy back in Spain whose greatest desire was to obtain a microscope. Welcome, Carlos, and thank you for agreeing to speak at our rounds.
Thank you very much, Alice, for this great introduction. And it does feel many times like that little boy that ran around Barcelona and was tracing all kinds of things to put under the microscope, because Barcelona and New York are in my heart, and they have offered me the opportunity to use that microscope surrounded by very wise people. So that's what I want to share with you today. A journey that I started almost a year around this time, that I never thought that I was going to take, and that put all of us a check. And it was a test to the opportunity that sometimes history gives us to work together. So that's what I'm going to present today. The work of many. Some of them have left us. Some of them due to the pandemic, some of them due to peculiar circumstances, including our beloved Mary Folks, the director of neuropathology and the autopsy service, from which I'm going to present some of the work that we did together and that we continue to publish, because even though she's not with us, definitely her spirit and her knowledge surround all of us. So that said, I'm going to share my screen. And I'm going to give you, again, a little bit of that journey that we took together a year ago in the context of how we are transforming observations and data into knowledge. That's part of translational medicine, and how important it is to have these exercises and to be able to work in groups that multitasking, but at the same time bringing different areas of expertise have allowed us to produce this new body of knowledge that hopefully is going to help and has helped in better guiding treatment modalities in this disease. So I'm going to divide the talk in three specific areas. I'm going to initially tell you a little bit how critical it is for us in pathology to provide testing, how accurate it should be, what it means in patient stratification, but also in treatment planning and monitoring, and which are the tests that we selected and why, and what are their sensitivities, specificities, and how they have helped us in guiding the disease. I'm going to then move into the second important connotation of pathology, which is understanding of disease process and the extent of organ damage. And I'm going to share with you some of the data from our autopsy studies. And I'm going to reveal that this disease, even though expected initially to be a disease of the respiratory system, through some of our studies and studies of others, we have learned that it's very different from what we expected. And finally, I'm going to be dealing with you a little bit on how the stratification of patients has allowed us to produce a staging that it's putting together the pathophysiology with the testing and the potential of treatment modalities and monitoring of our community of COVID-19 patients. And with that, at the end, also bring you some of the new information that we are producing using very high complex technology, single cell analysis and omics in order to further understand the complexity that is going to bring us back. And this is the enemy, this is the virus, the SARS-CoV-2, which is the virus that has been involved in this new disease called COVID-19. It's a complex virus. It's a positive and non-segmented RNA virus that it's quite large compared to some of the other coronaviruses. It produces 29 proteins, of which very few of them are the ones that we talk about, which are what we call structural proteins, such as the S protein, which is the one that is protruding from this matrix, from this membrane, and it's the one that it's used to lock into cells. It has the binding site, but also since it's the one that is protruding, it's the one from which our antibodies are directed against. The nuclear protein, the envelope. But besides these structural proteins, these viruses produces 24 non-structural proteins. And as I'm going to tell you a little bit later, these non-structural proteins are very, very, very critical for the functions of this disease and for the symptomatology and the observations and the problems that this virus is producing. And I'm going to start with a slide that I'm going to end essentially the discussion with. This is a very complex disease, and we are just touching the surface. And these are, not necessarily the most exciting news, but it's exciting from the point of view of science and of clinical management. In general, we talk about the ACE2 as the receptor of the SARS-CoV-2 virus. The reality is that this virus has multiple receptors for which it can enter cells. And working with Bobby Sivra at the single cell analysis level, we have been able to prove, and we are publishing that there are some receptors that may be more important in a specific organs. And something that we need to pay attention, because then the pathways that they are activated may be different, and so is the symptomatology that some patients bring forward when they come to visit us. So an important part of the talk in the context of understanding the complexity of this virus, the complexity of the entrance, how this entrance happens, because it needs the receptors need to be cleaved, and this cleavage happens because of a specific membrane-bound enzymes that cleave proteases, that cleave these receptors in order to then go on and produce more virions, but also the symptomatology by interfering with very specific pathways. So we'll talk about that towards the end of the talk. So which are the contributions of pathology in any situation, in any disease? The main contribution of pathology is that we are expected to assist in rendering a diagnosis. And the diagnosis has become more and more also part of the prediction and also part of assessment of potential therapeutic intervention, as well as monitoring, the population that either it's at risk, has the disease, or has had the disease in order to monitor the symptomatology and what's happening. So from the very well beginning, we knew that we needed to do something that was going to be not only a diagnosis, but a plan that could help in guiding the disease and understanding the disease. We were very fortunate to have a group of colleagues in microbiology that actually are just essentially a floor, above me in the 16th floor of the Annenberg building. So we have had a great relationship with Dr. Palese and several colleagues in the microbiology team, from Adolfo Garcia Saste to Florian Kramer, Viviana Simon. And as they were informing me in early January, end of December, that something new was developing in Wuhan, and then we started to see that it was moving in Asia and later in Europe, we knew that was not a matter of if, but a matter of when. So we had time, we had a little bit of time to work together and to prepare ourselves. Florian Kramer had been studying the proteins and was producing antibodies against the spike, was developing peptides. Garcia Sastre and Viviana had access to the sequencer, so they were preparing primers. So when we sat down together and when finally the first patient came here in New York in this institution, we had been thinking about it and we have been talking about it and we have been preparing ourselves. So we didn't want just to say yes or no. This is not what pathology does. And working with you, you know that better than many other teams. It's about numbers. I mean, we cannot say to somebody you have diabetes because you have sugar in your blood. Come on. It's a complex disease that has complex pathways, and how we approach it has been growing with the body of knowledge that we have obtained. So we look not only at glucose, we look at very specific proteins. We produce algorithms. So we said we are not going to be one of the groups that is going to say yes or no for the presence of the virus or the presence of antibodies. We are going to have qualitative and quantitative assays. So in the context of diagnosis, for the detection of the viruses, we set up a couple of high throughput approaches with the Roche system. That it's a yes, no, but also can give us CT values. But additionally, we wanted to do viral loads on quantitative PCR, and also we have been studying the potential mutations, which I will not really talk about. But very critical for us was to know that different individuals may be having different natural histories because the number of viral copies were also different, which in other diseases such as SPV or hepatitis, we already have proven. The next step was to do something similar to monitor the disease, because if nature has given us an enemy, which is the virus, nature has given us one of the best treatments, which is our own machinery of the production of antibodies. When functional, being capable of not only identifying the virus, but also of neutralizing the virus. So we said we need to have a test that will not only say yes or no for the presence of antibodies, but will give us a titer, a sense of how many antibodies we are producing, and also to link these units with functional mechanistic insights in the context of being capable to produce viral neutralization. And since these individuals were also producing a very peculiar immunological reaction, we wanted to make sure that we could also monitor cytokine production and a series of inflammatory markers that have become very critical in order to understand and stratify the patients and treat some of the patients. And finally, another important contribution or expectation from us in pathology is to understand the nature of the disease and the extent of organ damage. And for that, from the very well beginning, the first day that the first case arrived, one of the first persons that I called was the chief medical officer, our forensic chief of New York, Barbara Sampson. We are very good friends. We cross paths. Her husband is a molecular pathologist that trained with me, and now he's at NYU. And I said, Barbara, we need to work together. We need to understand this disease. We have done that in the past, during September 11 years ago, trying to help each other in forensic sciences. Let's try to do as many autopsies as possible to understand this disease because it seems like it's different. And I'll share with you the findings from a very extensive collection that now we have made available. It's probably one of the largest collections of fresh rapid autopsy materials in the world. We have done by now over 140 COVID-19 autopsies. So let's just start in the beginning. What is the test that we are using essentially for diagnosis? So it's based on molecular genetics of recognition of the molecular signature, the fingerprinting of SARS-CoV-2. It starts with a swab in your nose, in your throat. We have moved into anterior merits, but also now in saliva. We need to heat inactivate because it may contain viruses in the positive cases. And then after RNA extraction, essentially we are going into the detection of the products of this PCR. And interesting enough, the green flat lines are the patients that they are negative or individuals that they are not affected with SARS-CoV-2. But as soon as you recognize the specific sequences of the virus, you start amplifying and you produce these curves. And on routine days in the beginning, we observe this kind of picture. Most of the curves that were produced, more of the elevations and detection of the viral sequences happens between cycles 24 to 34, 35. By 38 cycles, you are peaking. And this is what we are used to. But we saw some patients that very early on started producing amplification in a PCR, and also some delays. Some people thought that the delays were false positives, and the reality is that it is not. So we said these are individuals that have a very high viral load that produce CT values very early on. These individuals are individuals with a number of copies that is very small. And we started to accumulate this data as quantitative data rather than just qualitative data. And we were one of the first, if not the first, that was able then to associate the viral load, the number of viral copies per ml of the body fluid in which that preparation was brought to us from nasal swabs, for example, to observe that in patients that were coming to us that were very sick and needed hospitalization initially, the patients with very low viral load did much better than the patients with high viral load. And that was one of the first papers, again, if not the first paper, to point out that in the disease. Now we have tens of thousands of these values. We are preparing a couple of larger studies because even at presentation, this is one of the most important biomarkers that we have to start stratifying patients. So what we learned from testing in the context of diagnosis, we learned that this is a disease in which viral loads can be associated with a more difficult disease, a more aggressive disease, and with disease progression and death. This is an important biomarker that we need to dwell further. And we pointed out that we were doing sometimes too little too late. In the beginning of this pandemic, when people came into our institution and they didn't have really fever or very low fever and they didn't feel too badly, we sent them home essentially with Tylenol and chicken soup. And that was not the right thing. There were people that 3 or 4 days after came, they were very sick. And by then the viral load had increased. And we learned in the process, as we were able to produce new treatment modalities, that, as we will discuss later, that antiviral agents should be produced more upfront. And let me initiate a discussion that will come at different points of the presentation. This is a different disease in many, many aspects. And one of the critical aspects of this disease being different is the fact that many patients don't develop fever even when they are very sick. The first SARS, the SARS-1 and MERS, were diseases in which a very similar viruses produce in essentially all of the patients, over 90% of the patients, high temperature. So for that reason, for MERS, if you may remember, in airports, they produce these doors that you go through. It was the beginning of a new epidemiology for the screening of disease based on body temperature. It doesn't work in here. It doesn't work in here. As I'm going to show you, some individuals that die at our institution, and I performed the autopsy, their body temperature when they came into the hospital very sick were 37.1. Why? I'll tell you why towards the end of the discussion. This is a different disease that presents different, and the more biomarkers and the more guidance, scientific guidance we can have from the beginning, the better we can deal with the patients and the better we can monitor their disease progression. So after the development of the infectivity period, our body starts recognizing non-self and sees the viruses as a pathogen, and our B cells start making antibodies. It takes time. So in the beginning, we were a little bit impatient, and we started to look at the blood of individuals after 7-10 days of infectivity, and the amounts of immunoglobulins that were detected were minimal. They were not there. So we kept monitoring to realize that after days 14, 18 to days 21, 24, it's when the IgG, which is really the functional immunoglobulin that produces neutralization, comes up. Early on, IgA, which is the secretory immunoglobulin, starts making some effects, difficult to measure, and IgM comes back after that, but the IgG were the immunoglobulins that we wanted to detect. And we did that based on a test that it's an enzyme-linked immunoabsorbance assay, what we call an ELISA. An ELISA is based on the identification of biomarkers that they are in the blood and in the serum or plasma. For that reason, it's called serology, this area. And we produce a plate-based assay that it's very simple, it's very cheap, and you can have in all of the laboratories. So we thought we need to produce a PCR that can be done in any lab these days, and we need to produce an ELISA that can be produced in any laboratory, that it's fast, that it's cheap, and you don't need huge machineries if we need to bring part of these assays into other sites, other countries, or in laboratories that they are not as sophisticated. So that was one of our paradigms. So essentially, in this assay, what we do is that the antigens that they are produced in the Florian laboratory or in other laboratories are then put back into each of these wells in the bottom. They are solid in solid phase right now. And then it's a matter of diluting the blood and seeing if the antibody is present that can bind to the antigen and producing a colorimetric reaction. In this case, the colorimetric reaction it's a different connotation from yellowish colors. So the ones that they are completely white is because they are either negative controls or individuals without antibodies against SARS-CoV-2. And as you keep saying, keep diluting and keep seeing it, some people have low levels of antibodies, some people have very high levels of antibodies. We turn this optical density kind of approach into arbitrary units per ml, and more recently into international units of COVID-19 antibody detection. And we have been working with the WHO to produce the standardization of these kind of assays together. And actually, we had a conference call yesterday with the WHO, and the standards are going to be published this week. We have been working with them, And we think that our assay is going to be one of the standardized, one of the first, if not the first, assay proposed with the standardization in order to be able to amplify it and to share it and to have a sense of what is the immune response of the individuals, as I'm going to share with you in a moment. So our assay, it's a peculiar assay. It's an assay that has two different steps. We call in laboratory medicine orthogonal assays, the ones that have two different steps or more than one step. And it's against the spike protein. And this is very important because the spike protein is, again, the protein in which the binding receptor, it's located, and also the protein that the antibodies can recognize because they are the ones protruding from the surface. And this is very important because some people have called me saying, doctor, I had the disease, I might have the vaccine, and I went to get my titers and they are negative. And you say, how come? Well, let me tell you, many people don't look at the spike protein for serology. They look at the nuclear protein. This is wrong. The antibodies that we produce, they are not against the nuclear protein. They are against the spike. So important to connotation to understand what we are looking at, what we are asking for. So, and this is the crystallographic structure of the S protein. The entire S protein is a complex molecule. It's difficult to produce synthetic peptides, and it's difficult to crystallize it, and it's difficult to have enough of this antigen to put in the bottom of a well. It's expensive, it's difficult. It's for that reason that we decided to concentrate initially in the receptor binding domain, which anyway is the functional domain. You want to know what's happening there. So our first assay deals with the RB, and as soon as the RB is positive, which is the qualitative yes or no, we go into the second part of the assay and we look at the entire S protein in order to produce this quantitation. What is the positive predictive value of this assay? 100%. And by now we have done more than 150,000. By the way, we have done more than 500,000 SARS-CoV tests just in our institution. And the predictive value is of 99.6%. So this is almost a perfect assay. And I need to give the credit to Dr. Florian Kramer to produce this very highly sensitive and specific assay in a research lab that we were able to gather to translate it and to even produce some improvements in the clinical lab based on regulation and based on questions that the New York State Department of Health and the FDA asked us to address. So we have an assay that it's very robust and it's highly specific and sensitive. How this assay helped us from the beginning of the disease? Since we were one of the first to have, not the first, to have an assay that was not just qualitative, yes or no, but quantitative, we were able very early on to address questions that the patients were asking us, that you, my colleagues, were asking me, and that government at some point were asking us. So we were ahead of the pack because we were prepared. Question number one. Do we produce antibodies when we are sick? Yes, we do. But antibodies are like the noses, they are different. So some people produce very high levels of antibodies, some people produce intermediate levels, and some people produce very low levels of antibodies. So is this important? Yes, it is important. Because if from the very well beginning you produce low levels of antibodies, you may not be able to function better. Second question, are these antibodies going to be here for a while? And of course, the sooner you start these studies, the better, because then you have more time for following up these individuals. And the reality is that yes, they can be here for months, but yes, they can decrease with time. So yes, we do produce antibodies, and yes, they are with us for several months, some of them for more than 9 months that we have been following, but some of them decrease relatively fast after month 6 or 7. And the third question was, are my antibodies capable of neutralizing, are functional? Yes and no, because if you reach certain amount of antibody concentration and titration or levels, Yes, you can neutralize 100% of the viruses, but if you are in middle or low titers, the chances that you can attack all of the viruses that they are attacking you are around 50% or less. So which vaccine is better? Which vaccine produces more antibodies? How long the antibodies are going to be there? Do I need two injections? All of these questions cannot be answered without an assay, a test like this one. And the more we delay in testing people vaccinated, the more time we are going to need in order to address these questions. And this was important because we realized that individuals with very high antibody concentration could help people that were sick. We could extract the serum, the plasma from these individuals, isolate even antibodies, and donate either this convalescent plasma or try to clone B cells in order to clone the immunoglobulins to have clonal antibodies. We have done that. And we realized that if we selected well individuals that had a very high antibody titer, a very rich antibody blood against the SARS-CoV-2, when we transfer this convalescent plasma into individuals that were very sick, these individuals did much better than the individuals that did not receive convalescent plasma. And that was one of the contributions of this institution. The fact that we were able to identify individuals with high titers, the fact that they were willing to donate the plasma, and the fact that we were able to transfer that into patients that were very sick. And while the period of being very sick for which our antibodies are not produced, we can help by giving you the antibodies of individuals that have been able to solve the disease. Again, when in the beginning people were asking me, well, doctor, there is no treatment for this disease. Well, nature has given us the best treatment, the antibodies, let's use them. We work with several companies in order to identify individuals with very high titers, with a lots of, of antibodies. We were able to isolate by flow cytometry the B cells, and then we were able to clone these cells, look at the production of immunoglobulins, select and then pick up a specific genetic manipulations to produce clonal antibodies that now Sorrento and some other companies are offering to our patients. So what we have learned from serology studies, we have learned that yes, we need an assay that is not just qualitative, but also quantitative in nature. We learned that these titers can be linked to neutralization, working with Dr. Florian Kramer and Viviana Simon, and that allow us to identify individuals that were, capable of donating their plasma to help others. And now we have done more than that. We have been selecting different individuals to produce the next generation of treatments, which is what is called Hyperimmune Serum. So it's not one-on-one, but it's many patients donating 3,000 liters of blood altogether in order to produce now a better selection of antibodies against more epitopes for the treatment of some of these patients, which we have started the clinical trial in this institution. And at the same time that we were doing that, we were monitoring the immune response to realize that these people were very sick. Some of these people were very sick. And that the immune response was a little bit different of what we used to see in other situations, because rather than one of the interleukins or few markers of immunity or inflammation to go up, all of them were very much elevated in some of the patients, interleukin 6, 8, the TNF alpha, interleukin 1 beta, to the point that we were able even to stratify patients with Miriam Mirat and colleagues based on specific immunological signatures. And that helped us in using very early on treatment approaches in order to produce either a cytokine blockade or to start using steroids and anti-inflammatories. But we realized that that one single receptor blocker was not as helpful. And based on everything that I mentioned to you, including this new puzzle, we realized that we needed to learn more about the disease. And this is when we went into a deep analysis of our autopsy material. And a lot of unknowns started to be more clear. And we started to see how this disease was a disease of multiple diseases. So I'm going to use a couple of autopsy cases just to illustrate what we are talking about. This is a 57-year-old female that was admitted into our hospital with fatigue, with body temperature of 37.3. So this is not really fever in my book. Concentration of oxygen was borderline, but the patient was very sick. And it was revealed that their inflammatory markers were all of them very elevated. You know, the C-reactive protein, which values are very low. Here you have them at 270, the ferritin, the dimers. And interesting enough, the lymphocyte count was quite low rather than as expected in some of these situations to be skyrocketing. So if anything, we saw more of a lymphopenia than a lymphocytosis. Patient starts getting more sick, the saturation of oxygen starts to drop, and in a matter of 4 or 5 days, the patient essentially dies of a disease that is very stressful, with all of the inflammatory markers and with concentration of oxygen that you cannot live. And when we did the autopsy, we realized that the alveolar damage was quite prominent, but rather than a pneumonia with a lot of inflammatory infiltrates, what the lung revealed was that the alveolar spaces were still somehow open with blood and a little bit of inflammation, but all of the walls were recovered by this pink material that are what we call hyaline membranes. So the oxygen arrives here, but it cannot go into the blood vessels because you have a barrier that is produced by inflammatory infiltrates, by the exudates, and by the process of alveolar damage that does not allow the oxygen to transfer from the airspace into us. We saw some hypertrophy of the heart, but very interesting, we saw that macrophages were very angry. They were phagocytizing. They were all over the place. They produced this kind of images under the microscope in which you can see the phagocytosis of the cells. And this is known as a macrophage activating syndrome. These macrophages, when they are very activated and very upset, they produce all kinds of cytokines, and they produce this kind of very aberrant immune response. So all of the markers of cytokine release and many of the markers of inflammation don't come from the typical site as we are expecting, but from this macrophage activating syndrome. By the way, the macrophage activating syndrome is pathognomonic of some diseases. One of them is the conventional canonical Kawasaki disease of children, which is a disease of poor origin, understanding of the origin, but for which the main target and the main derangement is this cytokine release that is produced by a macrophage activating syndrome. In one of the patients, on top of the viral damage of the lung, the patient also had bacterial pneumonia. In this case, was a gram-positive pneumonia. And I just want to show you the difference between a lung that is heavily damaged by a pneumonia with all of these infiltrates inside of the alveolar spaces versus the one that I was showing you before. All of these spaces which are still present in the lung of the COVID patient, it's really very different in a bacterial pneumonia. And the problem in here is that these hyaline membranes are as bad as all of these infiltrates, not allowing the exchange of oxygen into blood vessels. So that allows us to start producing the first hypothesis. Yes, this is a disease of a virus. Yes, this is a disease that is mostly respiratory in nature, at least in the beginning. The virus enters into the nasal cavity mostly, or into the oropharynx. It has ACE receptors and epithelial cells, it damages this epithelium, it produces major derangement of the inflammation, and it produces this kind of symptomatology that at some point produces this type of damage for which some patients can die. And yes, we did identify by electron microscopy multiple viral particles in many epithelial cells in the lung that were with these inclusion bodies. And yes, we observed all of the things that we just mentioned also at the different ultrastructural level, but we also started to see coagulopathy and signs that the virus was not only infecting the epithelial cells, but maybe the endothelial cells, that it was capable of going through the epithelium and maybe started to produce a dissemination and to produce a different kind of symptomatology and pathology in patients. And this is illustrated in this other autopsy. This is the history of a 68-year-old male that came after not feeling well with sore throat, shortness of breath, fatigue. Again, look at the body temperature, even when it came to see us, 37.1. But again, with markers of inflammation completely skyrocketing. But the patient also presented with night sweats, disorientation, neuropsychiatric kind of symptomatology. Doctor, I don't remember what happened yesterday. I'm an English teacher and I don't know how to spell words anymore. I'm foggy. And when we look at the medical history and talk to our colleagues, and they were saying this patient had something else. This patient developed atrial fibrillation, completely deoriented from the beginning. And after several attempts, the patient finally died. And that was not just the classical respiratory illness that we were expecting. So when we produced the next level of anatomical studies and microscopic studies, we realized very early on that, like in this coronal section of the right cerebral hemisphere, that you can observe multiple hemorrhagic infarcts, microhemorrhage, microthrombi, and big thrombi, which were confirmed by microscopy, in which the brain parenchyma was completely distorted by this kind of constant random alterations of coagulopathy, thromboembolisms, and hemorrhages. So then we pose the question, could it be that ACE2 receptors and other receptors that this virus is using for entry may be located in the brain? And years ago, when I was a memorial, I was studying the phenomenon of drug resistance to realize that what we call the blood-brain barrier, it's really a barrier because the endothelial cells of the brain, the capillary endothelial cells, are non-fenestrated, they are continuous, and they have several markers of detoxification, like the P-glycoprotein or what we call ABC transporters. So we pose the question, could it be that the ACE receptor is in the endothelial cells of the vascular endothelium of the brain? And the answer was yes, we detected it by immunohistochemistry. Later on, we quantitated that also, which allow us to produce the next generation of thoughts and a working hypothesis in which we started to compare COVID-19 into cancer. So like in cancer, a pathogen or a mutation affects a specific cell. And once this specific cell is affected, the cancer cells, or in this case, the pathogens, go into the blood vessels and initiate the traveling from the site of origin into a distant, either local or really organ distant site. We call this process metastasis. Metastasis is a terminology that comes from the Greek language that means traveling far apart, metastasis, moving far apart. And this happens not only in cancer. When we teach medical students, we say that metastasis is also a phenomenon that can happen in pathogens. When the pathogens are stuck in our nose, but all of a sudden are in our kidney, they didn't move because of that. They move because they can find into the tunnels of our blood system perfect sites for them to spread. And if then there is a mechanistic insight, meaning that the pathophysiology is there like receptors. Cancer cells use all kinds of matrix receptors and molecules in order to niche in different sites. And so this virus, when it goes into the area of the brain, it identifies in the endothelial cells these ACE2 receptors. It can produce thromboembolisms and can disrupt, it can produce different pathology. And the same when they can percolate into the liver, into the kidney, or into the GI. And that opened another interesting opportunity, because commenting that with Dr. Valentin Fuster and his observations of these patients, we realized that treating very early on some of these patients with anticoagulants could help them. And actually, this was the first study that was done by Valentin and the team here, proving that either prophylactic or therapeutic doses of anticoagulants were able to rescue 50% of the patients that were doing poorly. And based on that, the entire approach to the COVID-19 patient has changed. So based on all of that, we got together as a team and we said, look, we should have a better way of understanding that. And maybe we can help ourselves, the patient, and definitely the regulators, the policymakers, and society, if we produce some kind of an staging. I don't need to tell you, because in your department, a staging of chronic diseases is also something that you use. People think that we only stage cancer patients, but it's not the case. We stage lots of other diseases. And a staging is essentially a system that allows us to bring the pathophysiology with the right testing and the right therapeutic intervention with the right opportunity to monitor these individuals as well. And we realized that very early on, we were going to do better with our patients if we were going to be a little bit more aggressive, from the point of addressing inflammation, thromboembolic developments, and allowing some of the things that we were keeping for the end of the disease to be much more upfront. And that part of the staging system has helped us in also discussing and educating policymakers and individuals in regulatory agencies that needed to understand the dynamics and the complexity of this disease. So just before ending and as the first conclusions, conceptualized initially as a respiratory viral illness, it's clear that COVID-19 is a much more complex disease, producing through receptor binding and pathophysiological developments, endothelial cell damage, hypercoagulable state, also a macrophage activating syndrome, producing this prominent immunological response that underlines this excessive cytokine release. And in some of the patients, the combination of all of these pathophysiological developments produces a multi-organ failure to, in many instances, the patient dies of the disease. So to further understand what was going on, together with some colleagues in this institution, we have opened a door to start looking with new technology at what really happens at the cellular and molecular level using the materials that we have accumulated in the autopsy and in biopsies during this past year. To realize, as I was saying, that even though we concentrated our efforts in terms 2, which is a very good, well-known friend from some of us studying prostate cancer, because this is the membrane enzyme that is used for a specific translocation in prostate cancer. And the ACE2, this pair of enzyme receptor for cleavage, yes, they are important, but there are other receptors that appear to be as important or more important in this disease and in this disease process. So first of all, let me tell you what we have learned about the virus and what we have learned about the use of receptors. We said that many of these patients do not have fever at presentation. And they do not have fever at presentation because several of the non-structural proteins are meant to interfere with the interferon induction and with the recognition of these pathogens by cellular immunity. Also, the non-structural protein 8, as I'll show you in a moment, downregulates HLA, making the cell almost as a phantom when it's infected and allowing viral replication inside the cell without the system knowing that you are really being attacked. And also, like in cancer, some of the non-structural proteins mediate p53 degradation. So p53 cannot act in order to apoptose the cells because there is DNA damage or breakage. And also allowing the cell to multiply faster because it also upregulates the cell cycle. So this is a very, very smart virus for which several of the non-structural proteins are meant to make this cell invisible to the immune system. So this is how these proteins are being produced, and they are numbered because these are the first ones that they are being produced. So the first protein that is being produced is a protein that is going to inhibit the immune response, the interferon and the cellular immune response. And we learned that the non-structural protein A, it's the one that it's downregulating the HLA, meaning that once the cells are infected, they are difficult to be recognized because the antigen presentation, its machinery, is not really there. And we have been able to use new technology in a specific patients to start understanding what's happening. And this is a complex patient that died, and we were able to do a rapid autopsy with good tissues. And we realized that in this individual, at the time of dying, we were able to detect the virus only in the nasopharynx and in the lung. But many other organs were showing symptomatology of the virus, but the virus was not detected. I have some other autopsies that now we submitted actually this study to JAMA, in which similar patients that died, when I look at detectable viruses in all of their organs, I couldn't detect the viruses in any organ anymore. As a matter of fact, I detected antibodies in some people that died after a month of being in our hospital, for example. But the reality is that many pathways were absolutely altered. And interesting enough, when producing very careful dissection of the nasopharynx and of the brain structures, we have been able now to isolate specific areas to produce single cell analysis from neurons in different areas, the olfactory cells, pericytes, and so on and so forth, to realize that the ACE2 receptors, just very few dots are positive in some specific cells and some specific areas of the brain, while the VSG and other receptors are much more abundant in some of the cells. So this is something that we need to further unveil and that we need to further understand. And how these receptors are used to produce different pathologies is something that in this new study, we are going to start producing a working hypothesis. And I think that we are going to start seeing a picture that is a little bit more clear as these studies keep going on. Similarly, we have done high resolution spatial profiling using the nanostring approach, in which essentially what you do is that with multiple antibodies that they are identified by multiple fluorescent markers or different detection probes, we can then produce a molecular map at the single cell analysis, but in the tissue, which is also revealing that we can classify these individuals and that we can have very, very different pathways that they are activated and organs that they are affected if the individuals died of respiratory disease or if the individuals died of a major multi-organ dysfunction, as in the second case, in which also there was quite a bit of brain damage. So we think that that in the next upcoming months, year, we are going to be able to have a better understanding of the staging, a better understanding of this difficult disease. And what makes me very happy is when some days I come and I see these long files of colleagues and friends and community getting the vaccine, because vaccines work and vaccines produce antibody responses, which is one of the best ways for us to attack this disease. So I'm going to stop here, allowing for a little bit of time maybe for some questions. Thank you for the invitation, Alice, and thank you for the opportunity. Thanks.
Thank you so much, Carlos. There are some questions in the chat box. Emily, do you want to man that, woman that?
Sure.
Okay.
All right, so the first question is from Dr. Mark Sperling. Have you and your group looked at the histology of pancreas, especially islets, because the incidence of DKAs increased in patients with type 2 pathology?
Yeah, so we did, not maybe in the detail that it's needed, because in the first set of papers that we produced, we wanted to send a big note, then the big note was, this is not just respiratory, this is much more, we need to address it in a different way. And now it's when we are starting to be more granular, we have more time. We were surprised because in the autopsies, we didn't see a lot in the GI system, including, the pancreas. But this is now being reviewed at this kind of single cell level, and it's something that definitely I would like to follow up with you, because we need to start being, going from the big picture into the detail. We have these tissues, and we should be able to study that, and we are studying that well.
Dr. Nave asks if you could please comment on the new variants of COVID, and do you think the current vaccines will be as effective for these variants?
Yeah. So we are part of a consortium that has assembled the state of New York. This institution alone, we do around 200 viral genomes a month, and now we are expecting that to be a couple of hundred of genomes a week. So we have thousands of viral genomes done in the state of New York on a routine basis weekly. And many mutations have been found, but the mutations have not been so far capable of producing the virus that is more pathogenic. So when I try to explain that to other people, my colleagues, and even sometimes the students, what I say is that it's very different when a mutation produces polymorphisms that are interesting, but they don't change the function. So the color of our eyes doesn't really interfere very much with our vision. But if we would have all of a sudden hands with 20 fingers, that will definitely produce a different kind of piano player. So this virus so far is changing the color of the eyes, but not necessarily producing, aberrant developments that we may feel a threat. Most of the vaccines are against the RB, the binding domain. This is the key. If you change this binding domain too much, the virus will not be able to attach to the receptors and will not infect us. But maybe the best thing that can happen to us if the virus produces a mutation in the binding domain that would not be, but it will not do that. It's too smart. So what we have seen is the opportunity to bind differently and to have more avidity and affinity for a specific receptors. But since the vaccine is against this, so far all of the variants that have been reported don't appear to be an obstacle for the vaccines that we have.
So another question from Dr. Joshua Tannenbaum. Are there any clinical trials with Tempras inhibitors?
Yes, that's a good question. They have, the community observed, and I have some slides. I thought that maybe was too much, but we are working on that together with Arul, Shinayarian, and others. So it was observed essentially early on in Europe by a group of urologists, uro-oncologists, that patients with prostate cancer that were on an hormonal therapeutics did better. And it's because the androgen receptor, it's the one that gives the signal to TERMS2 as the transcription factor. And what we learn is that decreasing terms 2 avoids and diminish the ability of the viruses to be able to penetrate in the cells because the cleavage doesn't happen. So there are some clinical trials in Asia, in Europe, using an inhibitor to TERMS2 that has no major toxicities, and we are following this work. One of the things that we have done, and we are preparing for publication, is that we obtain lungs and nasopharyngeal biopsies from individuals at different times of ages, from age 7 to age 87, to realize that in the lung and in the nasopharynx of individuals that they are young, before puberty, in which the androgen receptor is not as elevated, the number of receptors is very, very, very low. That may be an explanation of why children don't get infected, or that they have a much more mild disease. Because one of the major receptors, in order to produce the real functional entry, needs to be cleaved with TERMS2, and that's under the control of an androgen receptor signaling.
So thank you for that. So it's 9:33. We just want to be mindful of your time. We have a few great questions left. If you have time to.
I have time. Yes, absolutely.
Okay, wonderful. So the following question is: have you considered looking at cells in the small intestine that make GLP-1 and GIP, as they may likely be damaged? This may impact the increase in DKA and type 2 diabetes.
Yep. Yeah, so that's another very good question. I'm very fortunate to have a group of colleagues in our GI section, guided by the very capable Dr. Noel Harpas, and that look at that very, very, very carefully. And in our first paper with Mary and the group, we didn't observe as much as we thought we were going to observe in the GI of these patients. So we are now working with the GI group in order to further understand what's happening. We have a very specific program with individuals with inflammatory bowel disease, but we didn't see as much of a derangement in the GI system as we expected. But again, the tissues are here, and if good questions can be posted, we should look into it, absolutely.
Are the current commercial antigen assays, including LabCorp and Quest, against the spike protein or other proteins? Are they sensitive enough to tell us an antibody response to the vaccine?
Yeah, so this is a problem because every company has tried to produce their own assays. I mean, they are not interested in the science most of the time. They're interested in selling the assays. So few of them are against the S protein. Many of them are against the nuclear protein. The nuclear protein may be a good target for specific things, but not to understand immunity and not to understand the effectiveness of vaccine. You need to look at titers that they are meant to look at the S and IgGs. So one of the things that we are doing together with the WHO, and we are going to start putting the paper together, this is the question. Can we molecularly define immunity? And the answer is yes. We can molecularly define immunity if we do it right. So one of the things that we are doing is we move from titers and optical density into arbitrary units, now in international units. So now we know what we are measuring. Okay, and we are measuring IgG, IgM, IgA against spike. Now what we are doing is using mass spectroscopy and MALDI-TOF, we are trying to identify the ability of these antibodies against this virus. And if we can molecularly define the bandwidth of the molecular profile of the immunoglobulin, in the context not only of how specific or sensitive, but really of important measurements, such as affinity and avidity and we may be able to molecularly define immunity, at which point we are going to be, talking with numbers, with metrics of what may be expected.
Okay. And then we have one final comment and question from the chat from Dr. Maria Scamagas. Thank you for your incredible work. And what is your opinion on antiviral nasal sprays to be used very early on in the algorithm? And for example, in patients who are asymptomatic?
Yeah, well, we think that that it's a good approach. We think that applying barriers at the entrance it's important, and it seems like some of these developments that are already being applied, they have no toxicity and they can help. So what we need to make sure is that the data is collected in a more scientific, clinical trial oriented rather than more random. I mean, important things are done slowly, and it's true that we have been in a wall of urgency, but we should not confuse urgency and importance, because these are two different things. So things that are important sometimes in an urgent fashion are not well addressed.
Great. So it looks like those were all the comments from the chat box. If anyone has any other final comments or questions, I think Dr. Stewart, you wanted to mention something?
Yeah, so first of all, Carlos, I mean, thank you for A, an incredible talk, and B, an incredible organizational effort and institutional commitment. I mean, what you've done and your team has done is simply amazing here and around the world. In response to the question about beta cell or pancreas infection with COVID virus, there's a nice paper in Cell Metabolism by Dirk Homan in the Diabetes Institute. And again, this is a credit to Dr. Cordon-Cordo, because they were able to use pancreases in a sort of multi-institutional study. And the best pancreases came from Sinai because they had the freshest autopsies with the least autolysis, because that's a big problem in pancreas. And so anyhow, the bottom line was that they found little evidence of infection of endocrine cells in the pancreas by COVID virus, but they did find, as Carlos so clearly delineated, endothelial inflammation, et cetera. So whether there's really an increased instance of diabetes from beta cell dysfunction in patients infected with COVID is I would say controversial, but so far it doesn't appear that there's intrinsic endocrine pancreatic disease.
Thank you, Andrew.
That's true. That's all from you. That's all from you, Carlos.
Yeah. But it's amazing, because at the end of the day, this is a disease that produces an endothelitis, that produces something that I never seen before, to be honest with you. So protecting blood vessels, not just anticoagulants, I mean, that anticoagulants is for coagulation, but protecting blood vessels may be something of interest. I know that there are groups that they are trying to protect the endothelial cell from specific pathways of damage. Some of the damage of endothelial cells are very complex patterns that start at the membrane level with ceramide. And actually this institution, China, years ago, was critical in defining new modes of endothelial cell apoptosis based on a damage of the endothelial cell that is initiated by the ceramide cascade, something for which there are now antibodies and some therapeutics. So again, another area of great interest that we need to keep looking more in depth, and we are going to do that. I think also that with single cell analysis, trying to move beyond the ACE2 and try to see which are really the receptors in each organ system that may be more critical, may tell us something that may be there, not at the level that we see usually, but that may be part of the pathophysiology that we are observing. I think that we will have this result during this year.
So I'm going to wrap it up, and I want to thank you again for, as I said in my introduction, for this Herculean effort that you have directed here at Mount Sinai. And my mom used to say, from lemons, you want to make lemonade. That was one of her favorite expressions. And somehow you've managed to make COVID exciting and, dare I say, even a little scientifically fun. So that's really a gift. And I thank you so much for sharing your work and your thoughts with us today.
Thank you. My pleasure. And again, if anybody has any specific question or any interesting development, we have lots of tissues and we have a resource that is there to be used. Thank you.